Welcome to the inaugural Collaborative Group of the Americas for Inherited Gastrointestinal Cancer podcast series. This series is presented by the CGA Education Committee. This year's series will focus on the multidisciplinary, patient-centered approach to management of Lynch syndrome. The aim of this series is to hear from experts about how they counsel their patients on cancer risk reduction strategies in Lynch syndrome. My name is Dr. Swati Patel from the University of Colorado, and I'll be hosting today's podcast. Remember, the content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or another qualified health provider with any questions you may have regarding a medical condition. We are honored today to have our first podcast series featuring Dr. Sonia Kupfer, Director of the Gastrointestinal Cancer Risk and Prevention Clinic at the University of Chicago and our 2017 President of the CGA. Today we will be talking about the general approach to how to discuss the multitude of cancer risks with our Lynch syndrome patients, the challenges our patients face, and the interventions available to decrease their cancer risks. Part 1 of this podcast will focus on how to counsel patients about the general cancer risks in Lynch syndrome, and will start a discussion on screening strategies for digestive cancers. Part 2 of this podcast will shift gears, and we will discuss the cancers seen outside of the GI system with additional risk reduction strategies such as chemoprevention and diet. Dr. Kupfer, thank you so much for being here with us today.
Thanks so much, Swati. And before we move forward, I just wanted to thank you in particular and the Education Committee of the CGA for really spearheading this podcast series and inviting me for this first installment. And I'm really looking forward to hearing the conversations in this series and in future podcast series. So thank you.
Of course. We're so lucky to have you as our first guest. Let's dive right in. So, Dr. Kupfer, when you initially diagnose a patient with Lynch syndrome and they're walking in with all of their Google knowledge, can you walk through how you explain why Lynch syndrome increases risk of cancer?
Sure. So, I think that the bottom line is that I explain that Lynch syndrome is really a problem of repairing. And so the problem is that DNA can't be repaired, and it kind of leaves mismatches in the DNA. And so I sort of give the image of mismatched socks. So there's something that doesn't quite fit. And if you're not able to repair DNA, ultimately that will lead to cancer. And you can imagine if this is happening in every cell of your body, there are different organs that can be affected. And then I explain that the way that this defect comes about is that they have inherited a genetic change, a mutation, in one of the 5 genes that is associated with Lynch syndrome. And that depending on which gene has that genetic change, they may be at higher risk of cancer in specific organs.
That's such a helpful explanation. I think when patients hear about genetic conditions, even when our colleagues hear about genetic conditions, they feel that it's a very complex field, and it's so helpful to simplify it with an analogy like that.
Yeah, I think even just speaking with our trainees, they start to, it's like alphabet soup. They start to kind of glaze over, and what was that MLH? What are you talking about? So I agree. I think, bringing it down to what's really happening here and what's the main problem, and then how does that impact how we approach screening.
That's such an intuitive explanation. Mistakes happen, and if too many mistakes happen and they build up, that can lead to problems, and that can lead to cancer. So what is your approach to discussing the multitude of cancers that can be associated with Lynch? That can be a very overwhelming thing for a patient to learn. How do you go about contextualizing all the different cancers that we see in Lynch syndrome?
Absolutely. And, that first counseling session, you can just tell that sometimes it is very overwhelming. So we, obviously are taking cues from how much the patient is sort of engaged and seems to be wanting some of this information. And I'll just make the point that I work very closely with a talented genetic counselor, Jessica Stoll, here at the University of Chicago, and I think that having a genetic counselor is invaluable and a must when you're, approaching these. Now, of course, some individuals don't necessarily work side by side, but certainly working on a team with your genetic counselor is very important because they're trained for this kind of a session, exactly this counseling session. So In our case, we both provide information for our Lynch patients on the cancers that are associated with the syndrome and also the cancer risks. And, I think many of us who are in this field like the NCCN guidelines, so the National Comprehensive Cancer Network comes out with guidelines updated on a yearly basis. And there's a wonderful table in there for Lynch syndrome where it lists the cancers and then breaks it down in terms of risk and mean age of onset by the specific gene that is involved. The other thing I like about it is it also compares those risks to the general population. And it provides risks up to age 70, which is a convention in the field, so we call that the lifetime risk. And here we can really, we sort of focus on which gene the particular patient in front of us, in which gene they carry a mutation, and that allows us to keep the conversation focused so we're not overwhelming them with, all the information about all the different genes and cancer risks. And then they also see, that the bottom line is that the risk is increased. And the risk is substantially increased over the general population. And so that's the bottom line for why we need to have them undergo more screening than what, let's say, their friend who turned 50 and says, oh, I only need a colonoscopy every 10 years. And we sort of, have this information about that risk comparison as, our example of why we need to be watching them more carefully.
Absolutely, and it sounds like that kind of introduction is really helpful in justifying our what seems to be pretty aggressive screening recommendations in Lynch syndrome to have a rationale for screening much earlier and much more frequently than the average patient. So specifically, as a gastroenterologist, the bulk of your practice, I imagine, is in colon cancer risk reduction. How do you talk about the lifetime risk of colon cancer with your patients?
Yeah, so just, building on using this table, let's say the patient in front of me has a mutation in MLH1, we provide them with the risk of colon cancer by age 70 that's somewhere between 50 and 80%, specifically 52 to 82%. I tell them that, this is based on a number of different studies, so you can see that there is what seems like a pretty wide range. And on top of that, there are other sources that we have that quote other rates, and they even break it down if you're a man or a woman. So, for example, the Multi-Society Task Force, which is an organization of a number of different professional organizations, has in their publication a rate for MLH1, MSH2 carriers for men of 27 to 74% lifetime, and for women 22 to 53%. So I explained to the patient, that there is this range. We don't know exactly where they will fall in that range, and that there's a number of different factors that will, sort of predict or tell, will sort of put them in that range. That being said, I basically say your risk is increased. And so in some ways it almost doesn't matter where they are in that spectrum, because we are going to institute screening earlier and do it very frequently. And because, I sort of explained that because of this problem with repairing DNA, this process can happen, more quickly than, someone who doesn't have Lynch syndrome. I was just talking to a patient yesterday who has Lynch syndrome, and her brother was diagnosed with cancer that seemingly occurred in a span of, a year. And she said, I didn't realize that this happened so quickly. And I explained that, yes, it can happen quickly, and that's the reason that we're doing, surveillance on a yearly basis in most cases.
And so when you dial down to specifics, what do you recommend for colon cancer screening recommendations?
Yeah, so the general, if you look across different guidelines or expert recommendations, the starting age is between 20 and 25. Of course, if there's a family history of very young onset colon cancer, then we, say to start 2 to 5 years before that earliest colon cancer. And then the recommendation, there's a range here too, somewhere between 1 to 2 years. In Finland, for example, who have been pioneers in screening for colon cancer and Lynch syndrome, that interval is 3 years. So just to show you that there is, there is this range. In my own practice, I will say that I'm okay with every 1 to 2 years until age 40, assuming that there wasn't a young onset colon cancer under the age of 40, and then after the age of 40, that I like to see them back on a yearly basis. And any of us who are in practice know that you say a year, that ends up being 18 months, sometimes that ends up being 2 years. So that gets us within that at least every 2-year recommendation.
Right. Life comes along, right? And before we know it, time passes. Okay. And so do you modify your colonoscopy screening start times or intervals based on genotype? You talked about how the gene that may be mutated impacts the magnitude of risk or the lifetime risk. Does that factor into your discussion with patients?
Yeah, interestingly, I can't remember which year it was, but the NCCN at one point actually started to make different recommendations based on which gene was involved. And I think there was a lot of backlash in terms of, do we have the data to support this? Do we really know that we can extend, for example, in a PMS2 mutation carrier, the interval, or we can start later? In general, I will stick to everybody starting at the same age. And then, we still kind of do every 1 to 2, we make the recommendation for every 1 to 2 years at this point. I think it's a really fair point, though, because I had, for example, a 75-year-old who was identified later in life to carry a PMS2 mutation because his nephew was found to have the constitutional mismatch repair deficiency, so that, sort of opened up the Lynch syndrome diagnosis for other family members. And he said to me, after having screened for a couple of years on a yearly basis, he said, can I stop? Or can I do this less frequently? Or can I do this in a different way? And I just don't think we have that data right now to make that recommendation. I mean, certainly, as with any patient, if the risk of doing the procedure outweighs the benefit that they're going to get, then we talk about stopping. But in his case, he's a very healthy gentleman, and so at this point I'm continuing. It does sort of tell us that we need to have more data and more studies in this area to know whether it would be safe to, do screening less frequently for PMS2 or to definitively start later. But all of us have those examples of the young patient who has who's PMS2 carrier who has, a colon cancer in his 30s and has a strong family history. So, it gives us pause to say, how can we identify the risk in any individual patient? And even within a family, there's cases I've had where a mutation skips, the penetrance seemingly skips a generation, and then the proband, the individual coming with a cancer in his 30s, but dad who carries the mutation never had anything in his lifetime. So there's, we all have our examples, and so we are sometimes hesitant to change things without really having definitive studies and data to tell us that what we're doing is going to be the safest for all the patients.
Yeah, it sounds like there potentially are other modifiers, and more data will hopefully unveil those to help us risk stratify those patients a little bit better, but an area where it sounds like all of us will be staying tuned.
Yeah. What would be wonderful is if we had, for example, less invasive ways that would be just as good to determine who, for example, a PMS2 carrier, could we do a stool DNA test that would tell us, you have a likelihood of having an advanced adenoma or a cancer, so, we got to do your colonoscopy now. But if they didn't have that, if it was a good enough test, then perhaps we could, skip a year or skip a few years. So I think, definitely staying tuned. I think this area is going to be changing, and we'll have more information in the coming decade.
Do you feel that your patients appreciate these areas of unknown when you have these discussions with them?
Yeah, I think it's certainly a conversation. This is the gray area of medicine where we have to take into account a lot of different factors. And I think being honest about it, that there's just some things we don't know. And I usually give patients sort of the most conservative approach and a less conservative approach. And I see patients that fall on that spectrum and in terms of what they choose. I'll say that for for individuals who come from families with a lot of cancer, for the most part, they want to be as conservative and as aggressive as possible. And so obviously within reason, and for which there is at least some data supporting it, I will do that for them and follow strictly guidelines for screening.
Speaking of the uncertainties in the field, how do you talk about the effectiveness of colonoscopy screening in Lynch syndrome? And you mentioned the sister of one of your patients who was pretty shocked at the rapid development of cancer. Is this a conversation that you engage in a lot with your patients?
Yeah, I think that at least for colonoscopy, compared to some of the other screening tests in Lynch syndrome, colonoscopy at least has studies to support its effectiveness. So many of these are observational studies that were performed in the 1990s and early 2000s. And, they do show that colonoscopy works in terms of decreasing the incidence of colorectal cancer and Lynch syndrome, so on the order of 60% less colon cancer in those who are screened, and importantly also decrease risk of death from cancer, so up to 70% reduction in risk of death. So I think colonoscopy definitely works, and the only thing I would add or say to that now is that the Lynch syndrome database that has been published on from the European group is a prospective database where they've been looking at mutation carriers who are presumably undergoing some kind of surveillance or are in a surveillance program. They found a high rate of cancers, and specifically colon cancers, in their patients undergoing surveillance. And I guess maybe that's good. It's expected. We're finding cancers. I guess my experience at least has been that hopefully by performing colonoscopy, we're reducing the risk of finding cancer down the road because we're removing precancerous adenomas. But that study has suggested that for MLH1 and MSH2 carriers, the risk lifetime of developing a colon cancer may be 40%. So there's been a lot of questions about whether this has to do with quality of colonoscopy. This database doesn't really tell us how good those colonoscopies were, but it also makes us question whether do cancers in the colon in Lynch syndrome perhaps develop without an adenoma stage. And in this area, there have been studies from the United States and from Germany that have suggested that perhaps that may be the case, that there may be these so-called mismatch repair deficient colonic crypt foci, or basically that the crypts of the colon have two mutations in the mismatch repair genes, and that this may lead to cancers that don't go through a polyp stage. So this is really just emerging, and at this point, we're still, moving forward with colonoscopy, identifying adenomas, but it does give us pause to say that, maybe these cancers will be developing not through polyps, but still, doing colonoscopy and doing it frequently will identify those cancers. And the good news is that from that European database, we see that the survival of Lynch cancer, patients with Lynch-associated colon cancers is extremely high. So still, I think, at this point, colonoscopy, we think, works and should definitely be recommended to all Lynch patients.
Sounds like the cornerstone of really risk reduction related to the colon, though as always, the story is always more complex. So shifting gears just a little bit to our other digestive organs as gastroenterologists that we take care of, how do you quantify the risks of stomach cancer, small bowel cancer, pancreatic cancer, and do you recommend routine screening for other digestive cancers?
Yeah, so here the data, especially when you talk about individuals who carry mutations, for example, in MSH6 or PMS2, the data is just not there. If you look at NCCN, the risks for gastric cancer are somewhere between 6 and 13% for MLH1 or MSH2 carriers and less than 3% for MSH6 carriers. And there may be differences here, too, between men and women, with men potentially having higher risk of gastric cancer, maybe somewhere around 8%, and women around 5%. In terms of gastric cancer screening, the current recommendations are to perform an upper endoscopy. Here, the guidelines and expert opinion kind of has a range, so somewhere between 2 and 5 years, starting at age 30 to 35. Something that's consistent among the guidelines is testing for H. pylori, because H. pylori is a carcinogen, and so if we can, reduce any kind of cancer risk in these higher risk patients, then we'd like to do that. The good news, I guess, is that when people have looked at the stomach cancers that develop in Lynch syndrome, most are intestinal type, and that's important in contrast to diffuse type, because the intestinal type usually is something that is visible when we so we can see it, and we have a better chance of diagnosing it at an earlier stage. That being said, there are really no studies at this point on the effectiveness of upper endoscopy screening. I do it, and I certainly, if there's a family history or any other kind of risk factors, then I'll do it more frequently, perhaps on a yearly basis. But for most individuals, I'll do it somewhere in that, usually 3 years is the interval that I pick. And certainly on the first endoscopy, or if they've not had it done before, I'll check for H. pylori.
And what about small bowel cancers in Lynch?
Yeah, small bowel cancers here, the risk is even, is lower. So the quoted risk for MLH1 and MSH2 for small bowel cancer is somewhere between 3 and 6%, not known for MSH6 or PMS2. Looking at the studies, many of these Lynch-associated cancers happen to be in the proximal small intestine, so in the duodenum, or in the very end of the small intestine, the ileum. And that's important because those are areas that potentially we can get to with our scopes. So when we do an upper endoscopy, we can often get down into the distal duodenum, which is the first part of the small intestine, and from the colonoscopy, we can get into the last part of the small intestine, or the ileum. So I definitely will, when I'm doing the upper endoscopy and certainly the colonoscopy, I'm definitely looking into those areas of the small intestine. I'll say that I have not picked up anyone by screening. I have had individuals who have developed symptoms or signs of small intestinal cancer. So by that I mean one individual in particular, he developed anemia. and it was an iron deficiency anemia, so we thought he was losing blood from the GI tract, and it turned out that he had a small bowel cancer in the ileum. And so, one of the things that I recommend to my patients on a yearly basis is just making sure they're not anemic. And if they are anemic, why are they anemic, and kind of, working that up. I don't, at this point, do routinely capsule endoscopy, so that's a technique where a patient swallows a capsule with a camera and it's taking pictures many times a second and sort of reconstructs the small intestine. I don't routinely recommend that, nor do I routinely recommend CT scans or MRIs to look at the small intestine. Those are called CT enterographies or MR enterographies. The individuals that I'll do those tests in are anyone who has symptoms, and then anyone who's had a personal history of a small bowel cancer and Lynch syndrome, or who have a family history. So that's how I decide whether to move forward with additional small bowel tests.
Thank you, Dr. Kupfer, for such a thorough and thoughtful discussion. Please stay tuned for part 2 of this first podcast in the CGA series, where Dr. Kupfer will review how she counsels patients about the other cancers we see in Lynch syndrome, and also review additional risk reduction strategies, including chemo prevention. Please follow us on Twitter at CGA-IGC. If you value this type of educational content, please strongly consider becoming a member of the Collaborative Group of the Americas on Inherited GI Cancer Syndromes. You can get details from our website at www.cgaicc.com.